All right, welcome everybody. Thank you so much for joining us. Happy Net Cancer Awareness Day. I am Mike Wayman from NCAN, and today we have a really cool program in store for you. We have two amazing specialists in the field of neuroendocrine. We have Dr. Thor Halfdonnarson from Mayo Clinic out in Minnesota, and we have Dr. Mary Maluccio, who's from New Orleans, Louisiana. Guys, thank you so much for joining us.
Thanks for having me.
Yeah, thank you very much for having us.
Yeah, so what we're going to do is we're going to actually talk a little bit about the new and exciting things that are coming up in the neuroendocrine field in terms of treatment for patients. And we're going to let these two doctors give us a little bit of information, a short presentation, if you will, and then we're going to do a little bit of a discussion between the two of them, possibly differing opinions, possibly not, but we'll get into that. So without further ado, I would like to introduce everybody to Dr. Thor Halfdonnarson.
Hello, my name is Thor Halfdonnarson. So I'm a medical oncologist at Mayo Clinic in Rochester, Minnesota. So I am here to discuss some of the new advances in neuroendocrine tumor management. And I am one of three medical oncologists who specializes in neuroendocrine tumor management at Mayo in Minnesota. But we also have neuroendocrine specialists at Mayo in Florida and in Arizona. So I wanted to really talk about some of the advances in nuclear medicine and theranostics for patients with neuroendocrine tumors, including advances in radioligand therapy or peptide receptor radionuclide therapy, which many of you recognize as Lutathera, and also talk about the role of radionuclide imaging in patients with neuroendocrine tumors. So I didn't bring any slides, but I figured I would just keep this conversational. So, and I wanted to start with mentioning the role of radionuclide imaging in patients with neuroendocrine tumors. So as many of you know, most of the well-differentiated neuroendocrine tumors do have expression of what's called somatostatin receptors on the surface of the tumor cells. So these are these little sort of receptors on the surface of the tumor cells that we can target in a variety of ways. So this is, for example, the target for octreotide and lanreotide. But we can also take a picture of this. So what we do is to give a chemical intravenously that sticks or binds to these receptors, almost like two pieces of Velcro. And this chemical that binds to the cells has this tiny little radioactive particle on it that literally just tags the tumor cells where they are, so we can give this IV, we can see where they go, we can see where they stick, and then we take a picture of the entire body and we see where the neuroendocrine tumor cells are. And this is called somatostatin receptor PET imaging, and you may have heard of this as gallium-68 dotatate imaging or copper-64 dotatate imaging or NetSpot or something similar, and the DetectNet is another name for this. So they are now, or these scans are now critical in our workup and assessment of neuroendocrine tumor. So if the tumors light up on these scans, we know that the somatostatin receptor is present on the surface of the tumor cells, and we know we can actually target that with medications like octreotide and lanreotide. But this is also the target we use for radionuclide therapy or radioligand therapy, such as lutetium-177, also known as Lutathera. So this is treatment that we have typically used in patients who have previously been on octreotide and lanreotide, and now that's no longer working. So what has been done in the past is that we start with the injections, the monthly injections, and at some point, unfortunately, for a lot of patients, the injections don't work anymore. So then we have a number of options. We could consider some chemotherapy like capecitabine temozolomide, known as CAPE-TEM, in patients with pancreatic neuroendocrine tumors. We can consider a medication called everolimus or Afinitor, or a medication called sunitinib or Sutent. But ultimately, we're going to be faced with this decision. We need to start thinking of radioligand therapy or PRRT. And the PRRT won't work if you don't have this target, if you don't have the receptor. So that's why we need to do the PET scan first. So we would typically use the PRRT after initial therapy, and it can be incredibly effective. It can stop tumor growth sometimes for a few years, and it's also incredibly effective in decreasing certain symptoms of functional tumors. Let's say the pancreatic neuron tumors that produce hormones, you can sometimes just stop them from doing that. And essentially over the course of a few weeks, the symptoms can mostly or sometimes even completely go away. The carcinoid syndrome you may recognize as flushing and diarrhea can certainly respond as well, but typically not to the same extent. But it definitely does seem to work there as well. So what has happened in the last year and is really exciting is that there was a clinical trial called NETTER-2 that looked at the use of lutetium 177 dotatate or Lutathera in patients with higher grade tumors, with grade 2 neuron tumors with KS7 of 10% or more, or well differentiated grade 3 neuron tumors. And in this study, patients who had previously not received any therapy, they were randomized to either high dose octreotide or sandostatin monthly or this PRRT or Lutathera. And then what was done is that what we call the primary endpoint of the study was called, or is called, progression-free survival, essentially measuring the time from start of therapy until the tumors grow. And lutetium dotatate was definitely much more effective than the high-dose octreotide in keeping the tumors from growing. And there was a noticeable difference, more than a year difference between those two. So what remains to be seen is whether overall survival or life expectancy is improved. And those numbers we typically don't get until a few years after the study is done, because it just takes a while to get those numbers. But at least we know that upfront the response rates are higher, the duration of response is longer. So this is something that I think can be considered for select patients with grade 2 and grade 3 well-differentiated neuron tumors. So very exciting. The question is, as I said, always, will this allow patients to live longer or live better? And that, I think, remains to be seen. There are some other trials looking at something similar. There's a trial called the COMPOSE that's looking at the radioligand therapy with lutetium 177 dotatate. So that trial is comparing the radioligand therapy with a couple of different chemotherapies, and we'll have to wait another year or two to get those results. And then you probably all have heard about the alpha particle therapy. So the alpha particles are almost like a next generation of those radiochemical drugs. So instead of using this radioactive chemical called lutetium, we're now using something called actinium or lead. And we're doing it the same way, targeting the somatostatin receptors. And these studies are now looking at patients who have previously received lutetium dotatate PRRT and now have growing tumors. So one of them is called Action 1. And in this study, patients who have progression, growth, essentially tumor growth on previous therapy with somatostatin analogs and even some other drugs are now being considered for treatment with this actinium PRRT, the alpha particle PRRT, versus your physician's choice of several different options, including high-dose octreotide or lanreotide or chemotherapy. So this is for patients previously treated with lutetium. And it's probably going to take us a couple or 3 years to get the results, but this is very, very exciting and might actually change our practice, change the way we treat patients with progressive neuroendocrine tumors. Some of these other studies are looking at patients with neuroendocrine tumors who have never had any radioligand therapy. And there is one study looking at the chemical called lead-212 dotatate, and that is a trial ongoing in several different locations in the US. There's a similar study looking at lead-212-VMT. So that's going on in a number of other institutions. So the message here is that there is a lot of activity going on in terms of radioligand therapy and the future of nuclear medicine and the management and diagnosis of patients with neuroendocrine tumors. So I think it's probably apt to say that the future of nuclear medicine therapy in neuroendocrine tumors is bright. So I think I'll stop there for now. Is that sort of what you were thinking of getting?
Yeah. No, I think that's pretty great. Yeah, there are a lot of exciting things. Now, Dr. Thor, where can people get involved? Where can people learn about these studies going on and learn about getting involved with these particular studies?
Great question. So I think the initial step is always whoever's treating you, your primary oncologist, I would start by talking to them and asking, are you aware of any trials, especially the trials that are nearby? So going on a clinical trial is not always easy. There can be frequent clinic visits, sometimes every 2 weeks, sometimes monthly, sometimes even weekly. So finding a trial as close to home as possible is always great. So I would always start with your local oncologist to see if they should know, and if they don't know, they should be able to find out.
Perfect. Dr. Maluccio, she's going to talk a little bit about histotripsy. That's a new and exciting thing on the net scene, sort of. It's a little controversial, but yes, Dr. Maluccio, take it away.
Thank you very much. Yeah, so histotripsy, just so that people can better understand like where it fits in treatment in general, is that it is FDA approved for primary and secondary tumors of the liver. It has very similar indications as other ablation techniques like thermal ablation, cryoablation, targeted radiation therapy, but that the benefit of it, or the advantage of it, it is non-thermal, meaning it does not generate heat, and it is non-radiation, and therefore it is safer around some critical structures. So to better understand the technique of histotripsy is that it is non-invasive, meaning you are using ultrasound. That's not the first use of ultrasound to treat certain abnormalities. And so lithotripsy, that is a low frequency pulsed ultrasound that's used to break up concrete, like, with kidney stones. And it has that jackhammer type sound to it while it's working. And it has been around to treat kidney stones forever. And then you have HIFU, high intensity frequency ultrasound, that is a continuous ultrasound that is used to generate heat. And so it is used to generate heat, and it is the heat that ultimately destroys the tissue. And therefore you have some of the disadvantages of heat dissipating in very sensitive areas. So the entire thrust of histotripsy is the use of high frequency pulsed ultrasound, where you are controlling the heat generation so it is non-thermal. And then it will respect the collagen content. That is the difference in the type of texture of a tumor versus the texture of an adjacent organ like a blood vessel or normal liver. And it respects that difference in collagen content. And so therefore it is safer around critical structures. So I'm super enthusiastic about histotripsy as a modality. As one of the 18 or 20 centers that have histotripsy, I think that we are learning about it almost every time we do another case. We've probably done around 36 cases now. It is extremely well tolerated. We have not had a single patient with a complication or an event that we would be able to link to that procedure. And I think the future of it is bright. Now that's with the exception of that we really don't have a lot of evidence to support where it fits in to the treatment algorithm for neuroendocrine. And that's what I think is super important, because people will latch on to something as a new and exciting technology, and it is new and it is exciting. but that where it fits in treatment algorithms is yet to be determined. And we have to be super careful in neuroendocrine because we do have a number of modalities with a lot of evidence to support them. So I don't want people to use it in exclusion of some of the stuff that's probably got some more definitive data to support it. So the strongest data in histotripsy is actually in primary liver cancer. Those are patients that have cirrhosis. So most of the data that's driving it is where you have very differing quantities of collagen in a primary liver cancer compared to the adjacent liver that has usually got some cirrhosis or some stiffness to it. And so it was highly effective in that, and that is ultimately what drove FDA approval in the indication for liver tumors. That doesn't mean it was only tested in primary liver cancer. So once that went through the FDA, you have a smattering of other primary liver cancers like cholangiocarcinoma or secondary cancers, in particular colorectal. So colorectal is not a rare tumor, it's a super common tumor, and metastatic colorectal in the liver, there's a lot of data to support a lot of things that we do in the management of the secondary site. So the studies that went on in metastatic colorectal cancer focused on patients that had really already been treated with other standard of care options. So what I usually tell people is that once people have gone through standard of care options, then you're allowed to be creative because you aren't then dismissing the fact that these other more data-driven therapies have been tried. And what they found in histotripsy in a good chunk of patients was that in treating one tumor, so they targeted a single tumor in a patient with metastatic colorectal, and in some of those patients, they actually saw this secondary response likely generated by the immune system that caused regression of tumors elsewhere. Okay, we call that an abscopal or an immune response, which is outside of the treatment area. And so that is what the buzz is on social media. That is what has brought it into sort of primetime attention. But I do want to make sure that patients understand that that's not the first time we've seen an immune response with certain types of ablative techniques. Irreversible electroporation has been around for several years. It has also been associated with the immune response and the abscopal response. Some type of PRRTs, as Thor was just saying, have also been associated in some patients with the generation of a response outside of the initially treated area. The question that everyone wants to know is that relevant to neuroendocrine? And I'm here to tell you that we do not know. Now, the fact that Rocky Mountain, so we have some neuroendocrine subspecialty centers that are getting histotripsy on board. I do think we will be able to at least answer some of these questions. But what I have for this audience today on National Net Awareness Day is that histotripsy is a very good ablative technique for treating individual tumors with high effectiveness. I can tell you that much. So we can aim that beam and we can absolutely destroy tissue. It destroys tissue by a process called cavitation. What we have seen in some of the neuroendocrine patients that are syndromic and or have elevated neuroendocrine blood markers is that has been associated with improvement in symptoms and a decline in markers. But I want to be clear, you also see that with other liver-directed therapies like thermal ablation or embolization techniques. So it's not, in general, anything unique. What we have not been able to show, at least in the 36 patients that we've treated, is that we have convincing evidence of a change in the immune landscape. We have not seen, in general, a response outside of the treated area like they saw in metastatic colorectal. But I want to be clear that neuroendocrine is unusual, even in PRRT and even in embolization. we may not see it as quickly as they see it in colorectal, because a lot of things will be delayed in neuroendocrine. We look at survival in years of time, not months of time. But that the immune response in general has not been as relevant in neuroendocrine outside of the high-grade histopathologic variants. So I am cautiously optimistic, but I don't want people running across state lines for a treatment that is still quite uncertain about its potential in neuroendocrine because of some magical theory that it's going to be related to immune response. We would be using it as a means of ablating a tumor, particularly a somatostatin receptor hot tumor driving someone's symptoms, and we're using the least invasive ablative technique that they have. And what I caution people against is that when we are using it instead of using a more standard of care option like embolization treatment, that has also got significant evidence to support it in the control of carcinoid syndrome, a lot of evidence to support it in the control of biomarkers like serotonin that are driving those symptoms, and come with exceptionally high objective response rates up in the 80 plus percentage points, with durable responses after 6 months of over 50%. So in summary, for histotripsy, I think it is an exciting new platform because it is non-invasive. The likelihood of it evolving into something that can take care of non-liver related stuff like pancreatic neuroendocrines that are in awkward locations where surgical procedures are risky, I'm particularly interested in it. If we would be able to find a treatment head or a protocol that is good for some of the base of the mesentery tumors that are extraordinarily difficult to operate on, it's just going to take us some time, maybe the next year or so, as those clinical trials out of Europe come to fruition, and we're able to then, as a neuroendocrine community, using people in Thor's position within the NANETS community, come up and say, hey, this is where I think it's most relevant for patients, so that we're just clarifying the narrative and better understanding the expectations that patients would have before committing to a relatively new technology. As exciting as it may be, it is new and relatively untested in neuroendocrine. And that is my spiel on histotripsy.
Thank you. Thank you so much, Dr. Maluccio. That, I think it is becoming a buzzword as we do some of these conferences and stuff, and people hear about it. It is definitely becoming a buzzword. Now, something that I did want to ask is as far as testing goes, is it different from a clinical trial, testing for histotripsy as a procedure?
No. So it is in clinical trials in PANC in Europe. It is in clinical trials for kidney, where there's no doubt it will ultimately make it through the FDA in kidney, just like other ablative techniques. When I say that we're testing it, is that we're using an FDA approved application. We're using it in the liver. And then I would say that most of us who meet as a group, as one of the histotripsy sites, we have a very similar experience, which is, as an ablative technique, it is an excellent ablative technique. If you can see it, you can treat it, and you can ultimately get the same ablative endpoint. My issue, though, is that neuroendocrine does not rely as much on the ablation of single tumors. We are dealing much more with multifocality. So I think that with that respect, where it fits in the actual treatment paradigm that we have become accustomed to, that is the uncertainty. And that's something that I think we're going to have to come up with as a neuroendocrine organization.
Okay. Now, so Dr. Thor, you brought up some stuff about new treatments being tried and things like that. I did ask about where you could find more information about clinical trials. but I want to divert this to both of you. In terms of a patient getting into a clinical trial, what is your what's the first piece of information? What's the first piece of advice you would give to a patient getting involved in something like that?
So I can start with that. So I think it's always a good idea to think about clinical trials, but it's especially a good idea if your oncologist tells you that things are not working, the treatment I'm on right now is not holding things back, tumors are growing. Then ask yourself and ask your oncologist, is trial the right thing for me right now? And the first step is really to try to find the trials. And I will say this, it is not easy to find who has what clinical trials. Even I, who have been doing this for decades, struggle with finding trials, and I can only wonder how people who don't live in this world, like me, the clinical trials world, find trials. There are certain websites that can help, including the National Cancer Institute, and I believe some of the neuroendocrine organizations have trials like a searching tool on their website, something that is AI driven that seems to be pretty good. And so you've got to find where the trial is. And the next step is really to go to the trial site where this is being done. And unfortunately, most of the time you have to go there in person. So they have to do the assessment to make sure that the trial is done for someone with your type of cancer in your type of situation. Well, we usually need to make sure that the kidney function, the liver function is okay, and then talk about the type of the trial. So sometimes these are what we call phase 1 trials, testing out a new drug, looking at what side effects there are, not so much looking at how effective the drug is. Sometimes we're looking at phase 2 trials where everyone gets the active drug, and we're looking to see how effective it is, but we don't really have anything to compare to. So those trials rarely lead to any sort of new FDA approvals. And then we have what I sometimes call the gold standard of clinical trials, a randomized phase 3 trial. Now we're looking at hundreds of patients, oftentimes, where the patients are randomized to get one intervention versus another. And it can be a new drug versus an old drug, or a new combination of old drugs versus old drugs. So it can be any number of things. And even comparing radioligand therapy with oral therapy, who knows? It's a lot of different things. Occasionally, comparing something to placebo. And I will say that in neurotumors, which are slow growing, placebo-controlled trials are still something that I think are appropriate, especially if we're looking at symptom control. Because if you're not comparing it to placebo, will you really know how effective it is, and or which drug is better? So I think carefully selected patients may be appropriate for placebo-controlled trials. So it all just sort of boils down to go to the place where the trial is being done, talk about the options.
Okay. Mary, what about you?
Yeah, so I agree with a lot of what he said. I don't think that it's an easy thing to navigate. So one, I think that I would emphasize what he said is that in unusual cancer diagnoses where we don't have a whole lot of lines of therapy, I think that clinical trials are super duper important, because they are often how we get some of the PRRT stuff that is actually well established in Europe and try to get it more mainstream into the US. I do think that the way that clinical trials are scattered through the US also makes it difficult for people with unusual cancer diagnoses, because it's not nearly as easy to find what you need, and you are way more likely to have to cross state lines in order to get it. And there are just those natural obstacles for it. And I totally agree with Thor that even when you are a medical oncologist, or you are an oncologist well-versed in a niche area like we are, it is not easy for us to know exactly what he has at Mayo Clinic versus what we have down here, right, versus what they have at MD Anderson versus what they have at Memorial. And so I think that it has to become, you have to be a really, really strong patient advocate. So just exactly what NCAN tries to do for patients. You have to be a really good patient advocate. You have to at least try to navigate NIH.gov. We just did that with the patient and found some trials looking at the mutation that patient had. But even then, it doesn't clearly tell you whether or not they'd be eligible. So there's not enough information readily available. And neuroendocrine is so heterogeneous that it's not even like you have the information. So it would be nice if we would look in an ideal world that we would say within our niche area, and what he's talking about in the early phase versus mid-phase efficacy trials versus phase 3 randomized control trials, if that we had an understanding of the compartments that we deal with, and almost like a running tally menu that was a little bit, you would think AI would help us do that if we can, like, I don't know, put like normal civilians in space. We could probably figure out how to navigate that by keywords that would at least help us trying to advocate, or patient advocates trying to advocate for patients in this arena, because I think that especially in certain parts of the country, there are significant barriers to access to clinical trials for no other reason than the providers down here are not sophisticated in order to understand where they would even look, no less be good advocates. And so if we're having trouble trying to advocate for our patients by calling around and finding what's out there, I think that patients within rural communities are likely never going to even know it exists. And I do think that there are definitely exciting things coming down the pike, especially in the radioisotope or theranostics arena, for which I think clinical trials could be a game changer for a lot of patients. And there may be ways to make, travel and hosting or whatever more accessible for people to be able to participate. I think that they are surmountable problems, but I think that it is very difficult to easily find trials and what the trial eligibility would be.
Yeah, one of the things that I do want to ask too is some of the things I know that sometimes people are very excited to get to become a part of a clinical trial, and it certainly is super important for people to get involved. To the people who are worried about, like Dr. Thor had said, the placebos, and the people that are worried about the travel and the logistics behind it, are there things that you think that, what are some questions that you think a patient needs to ask a doctor about some of these logistical things before they get involved?
So a couple of things. So with the placebo, I think actually we're going to see less and less of the placebo-controlled trials. So, but if there is a placebo trial being discussed, then I think a really good question would be to the oncologist: are you comfortable with? I would just say, are you comfortable with putting your own relatives on this trial? I think that's a fair question. So, and if you get a hesitation, well, you should think about it then. And I will say that there are certainly situations where placebo-controlled trials are reasonable. The other thing is that sometimes a trial is closer than you think. So you might travel to, and I've seen this in the Midwest. Someone comes from North Dakota to Rochester to talk about the clinical trial, and we have it open. And then I start looking, and we find actually open in Fargo as well. So all of a sudden, the distance went from like 8 hours down to 3 hours, and so those things we might help with that. And I will say, and I just had this discussion with a patient today who lives about 5 hours away, so was interested in the clinical trial. Some of the trials offered travel support. So that trial offered reimbursement for gas, lodging, and food. And because it's expensive if you have to come repeatedly if you have to drive 4 to 6 hours one way, sure, and stay overnight, or even stay over 1 or 2 nights or more. So it's really expensive. So definitely ask the trial coordinators, is there support for people like me who really want to be involved in this, but they just live far away? And tell them there are no dumb questions with clinical trials.
I think that's super important to let everybody know. Anybody who's getting involved with something that they don't know about is, ask the questions. That's super important. If you don't know, don't pretend you do.
No, some of the trials really put a lot of effort into getting like quality of life data. So they're not just not just measuring how effective the drug is, but how it affects your quality of life and your sense of well-being and things like that. So you can ask, what is this trial actually measuring?
Sure, absolutely. Dr. Mary, do you have anything to add?
No, I think that the questions, just like goals of care, I think it's a perfectly reasonable discussion to have even early on in the treatment process, because as Thor said, there are clinical trials that are bioacquisition trials that would potentially be looking at unique mutations within things or DNA methylation and how it does. And so you would be able to actually get involved in something that you won't necessarily know what it's going to change at that moment, but that it's not going to change what they're doing at the moment because the recommendations are going to be standard of care, but that it may, as information comes down the pike, may become relevant, and you would then be part of that process of it becoming relevant. And so clinical trials are not necessarily, as Thor said, they aren't necessarily therapeutic trials. They aren't necessarily drug trials. They can be quality of life trials and give us a better understanding of some of the emotional or mental health burdens of having a disease that maybe people within rural communities don't understand as much, and feeling like you're marginalized because no one really understands you. There are so many ways to get involved that may actually empower you to have a little bit more control, help you cope with the fact that you've got this problem. And then I also think that you can say, well, it would say, is there a reason for us to consider a clinical trial at this point in time? And why that becomes important is that as theranostics, as Thor was saying, as theranostics techniques are trying to work their way up earlier in the treatment paradigm, I think it's super important for you not to then jump into one treatment paradigm or treatment algorithm that would ultimately jeopardize your ability to go on to, say, for example, a new PRRT trial for people that have never been exposed to X, Y, or Z therapy. So I think that as you teach people at all of the NCAN patient conferences is better understanding your own advocacy. I try to tell people down here that are not really good at asking a lot of questions to physicians. They are so respectful that you're just like, no, get all these questions out, because it's really important for them to even understand how these decisions are made. People make decisions with different frames of mind. And so the questions about treatment options, how someone makes decisions with respect to expectations of response to different treatment options, and how clinical trials can influence that journey that they are beginning on. I think they can start even right at the very beginning, even if a lot of the new drug discovery type trials that are also very important are not actually going to be part of the medical decision making until later in the course, when we have already gone through the other standard of care options.
Absolutely. That's great. That's a really, really great. Now, if you're involved in a clinical trial, something I do want to ask too is, if the drug is tolerated well by the patient, will the patient be able to stay on the medication? And if it's not being well tolerated, or if, let's say, for instance, they just don't like some of the side effects and stuff like that, how easy is it for a patient to leave or quit a clinical trial?
That's a great question. So the short answer is that you can leave a clinical trial at any time point. So you can withdraw your consent to participate in the study, and that is often happens. And so nothing wrong with that. If you feel like this is not what you want to be doing, you can. As for these side effects, so most trials now have this built-in sort of a system where we evaluate the side effects. And let's say if you have side effects, we sometimes, if you want to stay on the study, we pause the treatment, and then we restart the treatment later, often at a lower dose, see if it's better tolerated. And then if you still have side effects, we can again pause the trial, restart at a lower dose. And so a lot of trials have those kinds of mechanisms. And some of you may be familiar with this drug called cabozantinib, which is not yet approved for neuroendocrine tumors, but there was a big study that looked at that, comparing that to placebo. And about 2/3 of the patients didn't tolerate the full dose, and they had to pause and start again at the lower dose. And a lot of times, just by pausing and starting at the lower dose, you find a much more tolerable dose. It's not like one size fits all. So some people are just more sensitive to certain side effects. And then if you just for some reason feel that this really is something you don't want to do anymore, you can always withdraw.
Okay. And in terms of if a drug is well tolerated, how long can the patient, or how long will the patient be able to stay on it?
Yeah, so my answer to, and that actually is a very, very common question, and naturally so, because it's a great question. So I tell my patients, you can typically stay on it as long as it works and as long as it's tolerated. Some trials do have like a defined duration of time. So, but sometimes the trial will actually allow you to stay on the active investigational drug as long as the drug is working, as long as you tolerate it, and as long as the drug is available. And there have been situations where the drug no longer is available, but in neuroendocrine, I have not seen that in a long time. So you can stay typically on as long as things are working well.
Have you ever found? Oh,
yeah.
go ahead.
If I were to add that one thing is, I do think that there will be trials, as Thor said, where one of the endpoints will be that we will be looking at duration of response or control of symptoms for X amount of time, and then it's almost like the Cinderella pumpkin comes and like 2 years and 1 day they're like, okay, we've done it. And so I do think that one of the things that I think makes some people skeptical, and I hope will not keep them from considering a clinical trial, because I think that if it is effective for them and working, it obviously is a great option for them over the timing of the trial. It can be extraordinarily disappointing. And as Thor says, I think a lot of trials are getting away from that, saying, oh, well, this is for 2 years, and then after 2 years, you won't be able to get it because it's not yet FDA approved, and so therefore you're left in limbo. And I can imagine that would be very frustrating for patients, especially when it is working. I think that even investigators like Thor and I, when we're looking at clinical trials, we are asking that question, especially when they think there's a high likelihood that it is going to meet its objectives, which is that there's a lot of preclinical studies or the early phase trials that would suggest that this is going to work. And then it is, well, what happens at 2 years? I think it's usually going to be a year or 2 years when then the company that's doing the trial is just trying to say they're trying to move to the next thing, which is then to submit it to the FDA so they can just get it on to market so we can use it however we want. So I would say that there is going to be print in there that will explain to any patient at any time what the length of the trial is. Some trials will then have an extension phase, which is either going to be a safety phase or a quality of life phase or something, but that there may be some fine print in there that says, but that this is not going to be forever. And so at least if patients understand that in the short term and they're tolerating and get a benefit, they're going to say, well, at least this is going to be for 2 years. And then they may have some extension phase where the patients where it is clearly working are continued on the drug in the long term. And then the patients with side effects will ultimately wean off of the drug and maybe consider another trial. But that I think the question is really for the patients where they did not recognize that there was some endpoint to this treatment because they had already met their mark, yes, that is a real thing. That the trial would only go up to an expectation of a year or 2 years, after which then someone would no longer have that accessible. I personally think that companies are going away from that for patients that respond to the drug.
I agree.
Great. And real quick about histotripsy, you mentioned that there's 18 places in the U.S. that are doing it. Does it? I was going to ask, is it widely available in the U.S. or will it be? What kind of progress does there seem to be on that front?
Okay, I think there's a lot of progress. I want to say there are at least 18. There may be a little more than 20 sites. I think with a lot of new technology, because you need to have your health system buy into a quite expensive machine, it doesn't make any logical sense. I can imagine that there are huge swaths of the country that don't have it within a 3-state radius, and so which is sort of unfortunate. But that what I like about how they are platforming histotripsy, and where I want to both reassure patients and other providers, is that as each new site comes on board, we have a peer-to-peer thing every month that goes over the issues that people are having, problem shooting, expectations, changing narratives, and things like that towards something that is a little bit more, again, accurate. But that I will say, they have gone from like 4 sites, 50 total cases, to now 18 to 20 sites and like 700 cases. So we aren't talking about something that we're dabbling in anymore. The issue that I have is, of those sites, even if patients with neuroendocrine are treated, they aren't being treated with the mindset of those of us that live in the world of neuroendocrine, and so their expectations are a little unknown. And the neuroendocrine sites that are on board are treating a whole gamut. As we know, there's too much heterogeneity to make strong conclusions in neuroendocrine. It takes a lot in the different categories: low grade, medium grade, and all those things, mid-gut, panc. And so I think that it's just going to take a while. With only a few neuroendocrine sites on board, it would take a while to get us up to critical mass. I think that maybe right now we have maybe at least 60, but not much more than 60. And from my peer-to-peer interactions with people, those 60 are all over the gamut. People with large tumors, low grade, high grade, previously treated with PRRT. And all I can tell people that I can convincingly say is, where you get the beam, because it's locking it in, almost like locking your car into a car wash, I feel confident that if you can see it and it is in your treatment zone, you're going to get the effect. The issue is, what is the long-term benefit of that over the other modalities that we have? So it's got to be something more than it's just non-invasive. But for people that are high risk for a lot of other techniques, for people, for example, that have had Whipple procedures where embolization techniques are associated with a higher infectious complication rate, oh, sure, I can imagine that I would prefer this over a lot of the complexities of treating those patients. And then, as I said, I'm very much interested in seeing it evolve into other way more complicated things that we have to deal with in neuroendocrine, which has to do with extrahepatic sites like the pancreas or the retroperitoneum or the pelvis, and the base of the mesentery, definitely. But I just think it's going to take some time, but I am very enthusiastic about it.
No, I would actually add to that I think it's critical that this is done at a place that has experience in treating neuroendocrine tumors, because the fact that you can do it doesn't make it the right thing to do. And so we have, and this is what I've seen. So we have a machine at Mayo, and we've been using it. And what I've seen is that someone who has a lot of different tumors in the liver, maybe dozens and dozens of tumors, and like 1 or 2 or 3 tumors were treated with no intention of treating anything more, may not really make sense. And also, I'll say that we do have perfectly got ablative techniques like percutaneous needle ablation. We have stereotactic body radiotherapy. We have embolization therapy, which all have a track record. So the question is, where do we fit this really new, exciting treatment in? There's no question that the treated areas are treated very well. And we just have to select our patients really well. And my only concern, there's a lot of buzz about the immune response with histotripsy. So my concern is that what I sometimes say, neuroendocrine tumors don't care much about the immune system. The immune system doesn't care much about neuroendocrine tumors. So immunotherapy has never worked for this disease. And so I think it just remains to be seen how effective, if at all, this immune response is. And that is, I think, where we need to do clinical trials. I could actually see a trial where we give something to enhance the immune system, like what's called immunotherapy, like Keytruda or pembrolizumab, with histotripsy. And now we actually are like generating this immune response and also making the immune system more aggressive. I see a lot of potential avenues for clinical trials in histotripsy. I'm very excited about it. Don't get me wrong. I'm very excited about the technique.
Yeah, I think that we are in full agreement that I think that there's been some embellishment out there on where it fits in neuroendocrine. And we are always at your patient conferences talking about the importance of at least getting an opinion, in your case, from someone that lives in the world of neuroendocrine. I think that is particularly important when you're talking about clinical trials and new technology. And I do believe that I completely agree that someone gets a technology, and then because they have it, they will try it thinking that it's going to have the same ultimate benefit when there's really, that hasn't even been studied. That benefit hasn't been studied. And so I would love for that to be one of the goals, as you say, hey, can we just all agree that the neuroendocrine subspecialty people are going to ultimately drive the narrative on where this new technology fits in to neuroendocrine, so that we aren't giving people unrealistic expectations because they're being treated in a more general community setting where they have a technology but aren't able to explain it in the context of the disease that they are treating. And I just think that's really important when you get into technologies like ablative techniques that can be approved for any tumor. So it doesn't matter what tumor it is. And then I think that I will reiterate what Thor said, is that I am only cautiously optimistic, if not even not optimistic, that we're actually going to realize the immune response component of it. And therefore, when you're doing it in someone with multifocal disease, I don't think that we have a lot of evidence to say that it is better or imparts a better expectation of outcome than many of the treatments that we have available. So I just think that it needs to be tested further.
Great. So one last question for both of you. We are rounding out the year here in NETs. I feel like for NCAN, like the November, the gala, the Net Cancer Day, that's kind of our year end as we get ready to ring in the next year of programs and stuff like that. What are some of the things that you're looking forward to in the new year when it comes to the NET community and development?
So I can start. So I'm actually, I always look forward to engaging with the NET community, both the patient community and sort of what I call my professional NET family, which is spread all over the US. So I look forward to seeing new clinical trials and hopefully seeing new treatments approved. So we are all waiting to see what happens with that cabozantinib drug. Is that going to get approved or not? So we're all really excited about that. And then we have these other trials coming, the alpha particle trials and some exciting things with high-grade neuroendocrine carcinoma. And then I really look forward to seeing the histotripsy data, how that plays out, and see some clinical trials there. And so for me, the next year is full of excitement.
Great, great. Mary, what about you?
I would say that from a patient standpoint, I think we came out of the pandemic making it more and more easily accessible for patients to get information by having like virtual patient conferences, educational sessions, these type of podcasts. So I think as we expand and get even more clever about getting information out there, I think that we are adding to the armamentarium of being able to give patients really critical information that gives them a lot more control over their care. And then what I would hope and am so optimistic about going forward is really probably the neuroendocrine community, because now we are not just like 5 centers scattered out all over the U.S. We are a lot more neuroendocrine subspecialists that live and breathe this disease and very passionate about future clinical trials, technology, and things like that, and clinical trial availability. And how can we, as a community, be somewhat more cohesive in how we manage to break down some of what I think are persistent barriers in access to care, because we are still scattered. I mean, we are a massive United States of America, and I think we still have swaths of patients that are struggling to actually get subspecialty care. And in the South, we've tried to decrease those barriers by getting cross-state licensure and being able to see a lot more people over the virtual platform, which is great. But I think it's more if we could come together as a neuroendocrine community, better understand all of the exciting things that all of these different subspecialty centers are doing, so that if patients could ultimately get something, even if they already have to go all the way to Minnesota. I just sent a patient to Minnesota for a valve replacement. Is that we would understand where those types of treatments are available, where we would be able to then guide patients a little bit better. And maybe I feel a little bit more sensitive to that because the South is just under-resourced. And so how we can better off take care of patients, even if they have to cross state lines, if it's to get better care, knowing that they can come back to us and ultimately get rerouted. I think as Thor and I both said, I think that some of the unique opportunities that may be available elsewhere are just not easily understood, even with those of us that live in the world of neuroendocrine, and how we can beat down some of those deficiencies as a community would be a really awesome, and I think ultimately raise the floor for neuroendocrine all across the country.
That's great. That's awesome. Thank you guys so much for participating in this. Thank you for always being so giving to the NET community. It's really special to have doctors like yourselves as a part of this awesome community of people. Everybody, stay tuned. 2025 is going to be a great year for NCAN. We've got four places lined up. I'm not gonna say anything for sure, but we may be heading to where Thor is right now. So we
just came down for me. So
yeah, we saw you already. We saw you this year. We also do plan on having. We're working on it. It's not 100% realized yet, but fingers crossed, we may have an actual in-person Spanish-speaking conference as well.
Wow.
So that's some new frontiers on the advocacy front as well. So stay tuned. If you want to get more information about that, go to netcancerawareness.org, as well as our social medias at netcanceraware. Thank you guys so much, and have a great Net Cancer Day.
I will close by really thanking you for providing quality educational content. I hear this in my clinic all the time. I went to NCAN, I saw videos, and so the work you're doing is absolutely critical. So keep up the good work. I'm delighted to be a part of it.
Thank you so much.
I have patients, they really like the podcast and they like the videos. And it
Awesome.
makes explaining treatment to people a lot easier. So yes, thank you very much for what you do. Thanks very much for having me.
Nope. Thank you guys. Have a good one.
You too. Bye-bye.